this is an effort where CMS is sponsoring. It's called Healthcare Payment Learning and Action Network that is doing pilots now in 4 states and wants to expand more widely that involve collaboration across Medicare from the federal government standpoint, Medicaid, and state employee programs from the state standpoint. And states are in the same boat as employers right now. I mean, they're facing high healthcare and rising healthcare costs and unmet needs for their own populations that they cover, and employers in these states. So starting in California, Colorado, here where we are today, Arkansas and North Carolina, where collaborative efforts are underway to move, as you said, from paying for services to paying more at the person level, these alternative ways of paying. And Rod, I think that's important to pick up on Lena's comments because we've got so much under treatment for things like behavioral health conditions and for conditions that people in areas with just less access historically to healthcare have continued to face, especially racial, ethnic minorities and others from worse socioeconomic status or rural areas, barriers that we just need to overcome. And it's hard to see, gosh, that seems really daunting. How are we going to do that when we're already spending so much on healthcare? But we've got so much over-treatment or mistreatment going on as well, that waste and inefficiency that you talked about. And while there's no easy silver bullet here, there is a shared commitment among many health professionals who have lived through COVID and don't want to do that again. You know, they want to see the next surge that we face from a new variant be one where the response is, okay, we're going to do testing, we're going to find people who have this, we're going to get them into treatment, we're going to make sure they're vaccinated and boosted, and we're not going to see a boost in hospitalizations as a result, or for conditions that right now are resulting in lots of hospitalizations, thanks in part to miscare during COVID related to diabetes complications or cardiovascular disease complications. We got to get better at meeting people where they are and use the effective diagnostic tests and treatments that we have to keep them out of the hospital. And the way to do that is to pay more for it. It's to switch the emphasis there. So common to these 4-state pilots is a commitment across many employers in the state. So for California, for example, PBGH companies are a big part of this, as well as smaller employers and the state. In Arkansas, Walmart, as well as smaller employers, are shifting to not only ask the question when they're renewing their contracts of, you know, what's my rate relative to Medicare and do I have an adequate network, but how strong is the primary care that my employees are getting? Are they having their risk factors checked and managed? Are they being screened for diabetes, for not just diabetes, but depression? And how are they doing on controlling those conditions? So these are questions that are increasingly being asked in benefit design contexts. And it's hard for employers to change healthcare by themselves. Even if you're a giant employer like Walmart in Bentonville, you're still only a small part of the overall market. But if you're working with CMS, which has made this shift into accountable, comprehensive primary care with accountability for total costs and accountability for outcomes a priority, and state governments that are also backing these shifts, it is possible to make progress. But at a minimum, these are like critical questions asked now. You know, not just the rates relative to Medicare, but the accountability. What are you getting for the total cost that you're spending in terms of outcomes and total costs of care increases? And how are your health plans and the providers within those health plans taking on this kind of accountability? And we're seeing that you can make progress. In the pandemic, the healthcare organizations that had already moved away from fee-for-service, that were paying on a basis of, you know, per member per month, more payments for their higher risk patients, did a better job. You know, they didn't, their revenues didn't drop out when we had the shelter in place. They already were using telehealth and team-based approaches to care and were able to expand on that. And that's really what we need now, Rod. And I think there are good opportunities for collaboration across the public and private sector on it.